Hello and welcome. My name is Dr. Monica Peak, and I'm a general internist and health equity researcher. I'm also a member of the board of Physicians for Human Rights, and welcome to our program today. I'm delighted to be here with several colleagues, including Carla Torres, who serves as Senior Counsel for U.S. Human Rights at the Center for Reproductive Rights, with Ms. Nia Mitchell. She's a Vice President at Reproductive Health Impact. Dr. Michele Heisler, who's the Medical Director at Physicians for Human Rights, and Dr. Nicole Freehill, who's an obstetrician and gynecologist in New Orleans, Louisiana. What has happened here in the United States? We know that there has been a consistent assault on women's reproductive freedoms across the United States, and that reflects not only an assault on women's rights, but as part of a broader assault on our democracy and bodily autonomy of all persons. And so this is really a perpetuation of marginalization of those of us who are socially marginalized that serve to exacerbate health inequities in our country. And so what I'd like for us to think about is, and talk about today, is how this particular situation affects not only women who are seeking abortion, the providers of abortion, but physicians in general. How this particular situation is not just a situation of abortion rights, but is part of a larger systemic issue around an assault for human rights for many people in this country. And so how can we use this as a case study of lessons learned as we begin to think about how we're going to be addressing these issues in other parts of our society? And so, particularly as physicians, where we may be increasingly in positions of dual loyalty, where we have our obligation to our patients, but then we have a competing loyalty to legal systems that feel unfair, to our employer, et cetera. And so how do we manage those? And so really, like no other time in my life, it has become evident that it's time for us as physicians to really speak out. And so the goal of this webinar is to sort of underscore that importance. So in part one of this session, we're going to talk about the situation on the ground and what it means for pregnant patients' health and for clinicians' abilities to provide patient-centered, high-quality medical care. And so, Nia, I'm going to start with you, and just note for the audience that the United States has the highest maternal mortality rate of all high-income countries, at a rate of 32.9 deaths per 100 live births in 2021. And we know that states with abortion bans like Louisiana and Oklahoma continue to rank amongst the worst for states with maternal health outcomes.
Our research findings showed that Louisiana's abortion bans, narrow and ill-defined exceptions, create confusion, uncertainty, and fear for both pregnant patients and clinicians. Also, the threat of punitive measures against clinicians also undermines the quality of care they can deliver to pregnant patients. And it also erodes their ability to use their medical judgment to provide pregnant patients with the standard of care. As a result, pregnant patients are being delayed or denied abortion care in the state. Also, those seeking an abortion must gather the necessary financial and material support needed to travel up, hundreds of miles to other states. And this is difficult for patients with limited resources and those living below the poverty line, people living in rural areas, as well as Black, Indigenous, and other people of color. And even though the stories we collected can't be generalized to everyone in the state, it really allowed us to paint a picture, a very disturbing picture of how harmful the impacts of abortion bans are, not just on patients, but also clinicians as well. And this is consistent with other research and evaluation that we've conducted that exposes the lack of access, quality, and continuity of maternal and reproductive health care in states.
I'm going to ask now for Nicole, our practicing OBGYN, who is working in a state that currently bans abortions. If you could talk to us a little bit about your personal experience and tell us how the narrow and ill-defined medical exceptions have affected the types of care that are available to pregnant patients.
Yes, so thank you so much for allowing me to join this panel and speak about the problems that are going on in our state of Louisiana. There are definitely problems with the defined exceptions for what is allowed for an abortion. And we also have, as Nia had mentioned, a lot of fear, a lot of confusion regarding the abortion laws in general from a physician standpoint that has created an atmosphere where patients are not receiving care in a timely manner, where patients are being transferred to other facilities, where patients are being turned away for situations that they should not be. A lot of patients, unfortunately, are not being treated at the standard of care when they're actively having a miscarriage or need some other kind of urgent care during their pregnancy. And as already stated, and this is a point I always love to bring out, is the maternal mortality crisis that we have. And this is only going to make situation worse. And our marginalized populations are going to be the most greatly impacted. And that is just something that we need to work against as much as possible on all the different levels. I think that from a patient standpoint, it's just as confusing and just as fearful, because I've had many patients ask me, if I talk to you about an abortion, am I going to be arrested? If I seek out an abortion, is that going to be a federal offense? I mean, there's all kinds of questions that patients are asking because they don't understand the laws as they are written, just like physicians are not understanding the laws as they are written.
So it sounds like one of the side effects that's happening is because there's so much uncertainty and fear, the physicians are foregoing care altogether, choosing not to engage in what might turn into a big mess and just sort of saying hands off and choosing not to engage in care. Can you talk a little bit about how this kind of environment has affected the patient-provider relationship, how you're able to make decisions with your patients, and how this sense of dual loyalty has affected you in making decisions that are in the best interest of your patients, knowing that you potentially have a conflict of interest in what may be best for you personally and legally.
I think that the dual loyalty is a very concerning aspect of all of this, because it is definitely the first time ever in my career that I am having to hesitate on what should I say, or what should I recommend sometimes to patients as far as what is standard of care and what of all their options. We are legally allowed to still counsel patients on all of their options, including abortion. However, we're not allowed to coordinate or create, an appointment, do any of the direct transfer of care for a patient who chooses abortion. So it is still very difficult as far as the ethics of what my medical training says I should do and how I should be helping a patient with coordinating their care and getting them any resources I possibly can versus what legally is said that I can do. And it's a very fine line and a very difficult line sometimes to walk, as far as helping patients but not putting myself in jeopardy. And it's something that I think a lot of physicians are choosing just not to engage at all, so as to protect themselves. And I understand where they're coming from. I mean, we've spent, all of us, years, doing all of our education, our training. A lot of us have families that rely on us. We can't be put in jail if at all possible. But that is a very big problem when it comes to our obligations and our ethical obligations to our patients. And that is a situation that I strongly believe any physician should not be placed in.
nearly every clinician we spoke with discussed ways that really the threat of being targeted for criminal prosecution had impaired the care that they felt able to provide to pregnant patients. And Nicole touched on a little bit of that, of feeling there's a target on your back because you want to do what's right for the patient, or having to provide care with one hand behind our backs, as one clinician said. Again, Nicole and Nia mentioned, but again, throughout these states, clinicians described multiple cases where they and colleagues felt that they had to delay or deny abortion care to pregnant patients. And I will say, we've talked about dual loyalty, but really what's this caused is incredible moral injury, really the moral anguish that you're not being able to offer abortion care to patients. But I will say that clinicians did express anguish also about their patients, especially their patients without resources, who wanted to terminate their pregnancies, but really were unable to marshal the resources.
As one maternal fetal medicine specialist that participated in our fact finding shared, I've had so many patients that have ended up not terminating because they just can't figure out how to be gone for their homes for days, for 3 or 4 days, which is what it takes. They don't have the resources to be away from home, and that's really tragic. These patients also describe the stress of trying to save enough money for an abortion in case they got pregnant, and the difficulty of making out-of-state arrangements for transportation, housing, childcare, and the actual costs of an abortion within a particular time frame. Unfortunately, these patients are or will be forced to carry their pregnancies to term, which will only intensify their hardships.
What's really interesting is this idea of a physician's conscience being coming into play. And I think that for so many of us who are listening to the national narrative, conscience has been used as a way to not be forced to provide, abortion services, which no one is ever being forced to do so. But what we're seeing is that a lot of physicians' conscience and their sense of moral injury is happening when they're not able to practice the medicine that we've been trained to do, as far as the full range of healthcare, and sensing that we're abandoning our patients and not being able to, do no harm.
The U.S. has ratified 3 international human rights treaties that recognize and protect sexual and reproductive health and rights. And those are the International Covenant on Civil and Political Rights, the International Convention on the Elimination of All Forms of Racial Discrimination, and the Convention Against Torture. Having ratified these, the U.S. is obligated to respect, protect, and fulfill the rights that are enshrined in them. And that means that it cannot take actions that violate a person's human rights, including by creating barriers to exercising them, and that it must proactively create an environment that enables their human rights. While the federal government is ultimately responsible for reporting to human rights treaty monitoring bodies about how the U.S. is meeting these obligations, state and local governments play a critical role in ensuring that the U.S. fulfills its international human rights commitments. And what we found in our documentation work in Oklahoma and in Louisiana is that the bans disregard the U.S.'s binding legal obligations and violate a constellation of human rights that protect reproductive health and autonomy, including the rights to life, health, equality and non-discrimination, information, privacy, and the right to be free from torture and other cruel, inhuman, or degrading treatment. And to your question about the federal protections that exist for clinicians when providing emergency medical care and how they may be at risk. So I'll touch on 2 federal protections. The first is HIPAA, the Health Information Portability and Accountability Act, HIPAA creates requirements for the use, disclosure, and protection of personal health information by health plans and healthcare providers, and that includes information related to abortion and other sexual and reproductive health care. The second, which has been in the news very much in the recent years, is the Emergency Medical Treatment and Labor Act, also known as EMTALA. EMTALA was enacted in 1986, almost 40 years ago, to ensure public access to emergency medical treatment, regardless of a person's ability to pay for the care that they receive. EMTALA provides rights to any person who presents at a hospital emergency room in a Medicare participating hospital and requests treatment by requiring hospitals to provide them with appropriate medical care. And because abortion care is indicated as stabilizing treatment in some cases, state abortion bans conflict with this federal protection and leave emergency care physicians in a really difficult position of, as you were mentioning, this dual loyalty of being beholden to a legal system, but also ethically beholden to provide standard of care to their patients. And of course, under EMTALA, providing stabilizing care, which includes abortion care.
Carla, I'm going to come right back to you, sort of continue our conversation about EMTALA and some of these other things. How can physicians support these efforts to change law and policy at the state and national level? And then what other initiatives is the reproductive health community pursuing?
Well, so one way that they can support these efforts is by acting as plaintiffs in litigation. So one thing that the center has done is filed lawsuits and complaints in several states on behalf of women who were denied abortion care despite facing severe and dangerous pregnancy complications. And in those same lawsuits, we represented physicians who are essentially unable to provide the medically necessary abortion care that patients need because of harsh criminal, financial, and professional penalties they face. Physicians can also join efforts to advocate for legal and policy changes in their state or nationally by, among other things, testifying in support of laws that repeal abortion bans or that would establish strong legal protections for reproductive rights, including access to abortion. Healthcare providers play an important role in educating lawmakers and the public about the harms that these bans are causing.
Excellent. Thank you so much. One just follow-up question. If someone wanted to be able to testify, how would they get involved and who would they call?
Sure. Well, so in the case of Louisiana, I'll speak for one of our partners who isn't on the webinar today, at Lift Louisiana. I think reaching out to organizations that are doing the work every session, going to the state capitol to engage with lawmakers and to educate them is really one of the ways in which you can get involved. Is look out for the community-based organizations or a national organization that is involved in this work and offer to provide testimony. A lot of lawmakers are persuaded most by people who have been directly impacted. And so I think if you have been directly impacted, as many people have, including physicians, and feel emboldened and want to share that impact with lawmakers, reach out to organizations who are doing the day-to-day work at the state capitals to try and either push back against abortion bans or limits on abortion, or to strengthen abortion protections in their state.
So first, medical and other professional associations are critically important to mobilize for advocacy efforts. So again, for those of you that are members of professional organizations, it's really important to work with your professional associations at the national, but especially at the state and local levels. And second, it's so important to mobilize and harness the voices and the moral authority of clinicians in all specialties. We can tell our stories. We can tell the stories of our patients who have been affected by laws criminalizing abortion, as well as telling the stories of patients that have benefited from laws in states that do protect the right to abortion care. Third, again, as Carla just said, it's so important that we engage in advocacy at our state level and to advocate for greater protections for clinicians and for patients at the federal level, while we also work to end laws creating the current dual loyalty crisis. We have to fight against dual loyalty situations, and we all have to fight against attacks on healthcare and on our patients.
One thing that I share on my own advocacy journey is that advocacy is many things. It is going to the Capitol and testifying. It is working with local organizations. It can be as simple and straightforward as helping your patient get their next appointment with the physician that they need. It can be as simple as making sure that they have resources to help them with getting transportation to a visit. I mean, you can advocate on such small but yet very meaningful levels, and there's all of these different levels you can advocate all the way up to a national voice. So I don't want physicians to feel like you have to be working with a huge state organization, a national organization. I think that's very important. But I think that anyone who's interested just needs to take the first step and just start an advocacy journey and see where it leads you. I definitely urge people to reach out to their local organizations. Lift Louisiana was instrumental in helping me start my advocacy journey and grow in my advocacy journey so far. And I think that is a testament to the power that they have and the amount of resources and the amount of dedication that organizations like that are giving to not only this issue and this cause, but also many others.
Yeah, and again, I think others have really given wonderful specific ways to get involved. I would say that I think one important first step is for all of us, especially those of us who are clinicians, to understand and educate ourselves about the links between the issue of full access to abortion care and other areas of health. I mean, in my clinical area, as Monica knows, and in much of my research, I focus on diabetes and helping people with diabetes. So, thinking about, my patients, the young women patients who absolutely would have severe health outcomes if they can't get early prenatal care because other physicians are afraid of providing early prenatal care. A strong focus of this panel has been just the ways that these abortion bans, the criminalization of abortion, is a health equity issue and impacts a wide range of health issues and human rights. I mean, there's a lot of focus on, structural determinants of health, of how policies and laws disproportionately harm low-income individuals, often communities of color. And I think it's really important for us to really think through and act and show the links between how important it is for overall health and well-being to have access to the full range of sexual and reproductive health care.
Well, I think we're going to have to end it there. I want to thank you all so much for your time and your energy, for your passion in doing this work, and fighting for the rights of women everywhere and upholding our democracy. I hope that everyone who has been watching has learned something and has been motivated to get out and join us in this fight. And I hope everyone has a great evening.